to Greece, and then you'll come back to me.
Okay, thank you, Roberta. It's an amazing demonstration to a real-life situation. And we will go now to Dr. Stefanos Bassioukas from Athens, Greece. He's an expert in ESD and third space endoscopy. So, Stefanos, are you with us?
Yes, do you hear me, Shaima?
Yes, hello. Finally meeting, huh?
Ok, buongiorno a tutti, mille grazie per l'invito, professore Roberto Dimitri e professore Alessandro Repizzi. That's all I know from Italian language. My anesthesiologist has studied in Italy, so I had the lessons yesterday. So thank you very much for your kind invitation. It's a great honor for our team to present this excellent event with so renowned moderators and performers, tough cases for endoscopic resections. Roberta, I think, has a very tough situation there, but she will succeed. She's so good at what she's doing. Let me see if my case is an easy one. So, can we see the slide with the case story of the patient? So, we got a 56-year-old male. He did an index colonoscopy at the December of the previous year. And during the index colonoscopy, he said to the doctor, okay, can you do me an EGD because I feel some burning sensation sometimes from there to there. So what they found is that there was a visible lesion at the GE junction, and the endoscopist took a biopsy that showed intestinal metaplasia with low-grade dysplasia. Correctly, they did a gastric mapping with biopsies that shows the mild intestinal metaplasia areas at the antium and a little atrophy at the corpus. Also, the patient was infected with H. pylori, so he did an H. pylori eradication therapy. So the patient came to us and did a second look examination due to the low-grade dysplasia, and we detected also this lesion there at the G junction. We can see it. I have placed some markings just to save time, and we see a lesion about 1.5 centimeters, 2A and 2C in the central depression area there. And we took only just one specimen that shows to us that it was a high-grade epithelial neoplasia. So I think that the only thing to do with this kind of patients is to resect visible lesions at this area because they may harbor intramucosal cancer or invasive components. So let me, first of all, let me do some characterization of this kind of lesions. We see it's at the posterior side of the gastro-esophageal junction. We see the central depression area here. I'm using from Olympus the EZ1500 new endoscope. It has the ability, like the Fuji endoscope of LCI. This is called TXI, texture and color imaging enhancement ability. So we can more clearly see the central part of the lesion, and also to delineate and define the borders of the lesion according to the surrounding mucosa. But if we switch to more in a narrow band imaging mode, we see clearly that there is at the central, there is this disorganization of the macrovascular pattern here. Also, we see that the vessels, the subcapillary vessels, have a distorted arrangement, and also the distribution is not so equally each other. We see some closed and open loop anastomotic areas between all these kind of vessels. So if we take a targeted biopsy from the center of this lesion, we have a good chance to have a good histology preoperatively. We see the magnification image. There is some wash there, mucus let's say, okay? So I will move my endoscope right now because you see my attachment cap is a black one. This is for diagnostic purposes. It's very soft, and so we're not going to make any harm, any injury on our specimen. So I will move my scope. I will put a transparent one cap.
Dr. Bassioukas,
Yes?
a question from the audience.
Yeah, of course.
In the slide presentation of the case, there is mention of a biopsy during the first esophageal gastroduodenoscopy. Okay,
Yes.
do you always perform the biopsy, or in case of this one, do you avoid it when the lesion is fit for endoscopic resection?
Most of the time I took just one specimen, and I pay attention to be as much as targeted as I can to have a histological assessment before doing further treatment, endoscopic treatment. So yes, I will take just one specimen just to have an idea what it's about. But of course, it's very obvious that here we have an intraepithelial neoplastic lesion, but I think that just one specimen is good for have an histological evaluation preoperatively. No more than one biopsy, because otherwise we induce too much fibrosis, and especially in the G junction, because we see that it's there's a small extension to the esophageal side. So if we take many biopsies from there, we can induce fibrosis, and then we're encountering problems like Roberta has for fibrotic areas. Okay. So I made the markings around the lesion, and I have to mention something. You see, at the lateral margins, the markings are about 2 to 3 millimeters around the lesion. First of all, let's do a retroflex endoscopy, just to have a better idea. Sorry. Okay, good.
So, Stefanos, from an educational point of view, can you just explain the strategy of how to resect? We know that we have a lot of techniques for ESD, so just a brief, what to do when.
Yes. So there are many techniques in this area you can do to have a good resection. You can do just a frontal dissection, and then after the middle of the progress of the submucosal dissection, go to the anal side and do mucosal incision, and in this way we join the cutting edges from the oral to the anal side. However, in my opinion, in my perspective, I do first of all an anal incision at the gastric side, and then I have no fear that the specimen, as I'm doing the frontal then dissection, is not going to flip over the anal side, so I cannot lose my orientation during my dissection. So it's much more easily to have a flap from the mucosal frontal dissection and then join to the anal side. But before doing something, before doing the operation, I will show my markings at the oral side. You see, it's a little far away from the lesion. The lateral markings are very close, 2 to 3 millimeters, but my oral markings are above 1 centimeter from the proximal sides of the lesion. And this is why that sometimes there is a subsquamous extension of this kind of lesion inside the esophagus. Sometimes it's prominent. You see a little bit elevation at the esophageal side, but sometimes it's not so prominent. So I prefer to do further markings at the proximal side, just if there is any component of the subsquamous epithelium to have an R0 resection. So if there are other questions, I will proceed. So
now, and you usually do marking in upper ESD. However, in lower, we don't need, because the demarcation is usually a bit clearer in colorectal ESD, right?
Yeah, in a gastric lesion, esophageal lesion, it's mandatory to have
yes.
markings before endoscopic resection. I agree with this. Okay, open.
So what
I'm using sclerotherapy needle from Boston Scientific. I found it's a good one for doing all this kind of stuff. I'm using right now gelatin solution.
What solution you're using?
Gelatin.
Gelatin.
Gelatin is the commercial name in my country is gelofusine. Is a high viscosity solution that is mainly used in intensive care units for oncotic volume. And you see, I'm doing the submucosal lifting. I try to be very close. My next lifting to very close to the previous one, not doing in different areas. Otherwise, we induce some valleys from the mucosa, so you have to inject all the time.
And do you prefer to put some adrenaline, especially in gastric lesions?
Yeah,
you don't do this.
In these cases, at the upper part of the stomach, I usually drop some adrenaline because there are so many penetrating vessels at the submucosa. So in order not to have to deal all the time with the bleeding points, I do some adrenaline. But in other sides of the stomach, like antum, I do not do adrenaline dilution.
Yes. And I'm wondering the position of your patient. Is it supine position or left lateral position?
No, it's a classical left lateral position right there. And it's intubated, of course. So especially for the beginners, I think that it's the patients in stomach and esophagus, you have to intubate the patients because sometimes it will take so many hours, and so don't have any fear for respiratory problems. Okay. So I did right now the lifting from the anal side. So I will do my mucosal incision with a classic dual jet knife from Olympus. In this area, I will do this with a 2mm tip knife because it's a little thicker than the esophageal side. Okay. So
what about your electrosurgical settings?
I'm using ESG 300 electrocautery machine from Olympus. I think it's not so clever like bio machines, but it's very plug-and-play machine. That means has a lot of modes that resembles to herb modes. For instance, we're doing the cutting instead of endocut with pulse cut mode. It's equivalent to endocut's eye, and then dissection we do this with pulse quad that is equivalent to swift coagulation. But I think it's a very easy one. Okay, so we see that our knife is protruded from the 7 o'clock channel. So in order to have a good incision line along my markings, I choose to do this from the left to the right side. Sometimes I have to switch this because the knife is not have a good, let's say, hooking of the mucosa, so I will sweep from the other side. Okay, I'm trying to be outside from the markings.
So thank you, Stefanos, for this very amazing and nice demonstration of the strategy and everything. And we will come back to you. We have to shift to
the procedure. Okay.
Okay.
Please, could the direction connect us with the Athens hospital?
Do you hear me?
Yes.
Yes.
We are,
So,
we are video linked with you for the terminal steps of the procedure.
Okay, thank you very much. What we have done till now, we're doing the anal side incision and then trimming. Trimming, what means trimming? Trimming is after the mucosal incision, we do a dissection a little bit at the level of the muscularis mucosae. In this way, in the upper part of the submucosal layer. In this way, we make the tension of the periphery is slackened, so it's much more easier for the cartilage mucosa to get lifted. So you see nicely how we have done this trimming around the anal side. Then we move to the frontal side, and we do a complete then mucosal incision. What is crucial for this is what will be the dissection plane after we go underneath the mucosal flap. So we see that we have to do a plane very close to the mask layer. In this way, we can see we have a total control of all the penetrating vessels from the mucosal layer, and not hitting the upper part where is all the network of the vessels from this penetrating network. So we have to pay a little bit attention to be a little close to the mask layer. Of course, we see some splitting areas here. They're not perforations. So if you don't do this, we are going to be at the upper part of the submucosal layer, the dissection plane, and sometimes we are hitting the underneath side of the specimen. So it's a little bit crucial, this step. Yes?
There is a question from the audience.
Yeah, of course.
Hi, Stefanos. This is Pradeep Bandari.
Oh, Pradeep.
Nice to see you. You're doing a great job. You are a super fast ESD expert. You do these things so fast. So great job. I'm just thinking for people watching in the audience here, if we use traction in this situation with clip and line, this could be finished in 5 minutes.
Yeah, of course. Thank you, Pradeep. Pradeep, you were my inspiration to go to Japan. I met you first time 70 years ago in NAD, going to see confocal endomicroscopy, and you told me that you was recently been in Kotoda, Professor Kotoda Center. So you were my inspiration to go to Japan. So this is for you. Okay. So to answer your question, yes, of course we can try if we have let's say the perimeter of the specimen is a little wider, then the specimen you see is going to flip over. So in order to stabilize the mucosa, we can do the tetaglyph floss technique nicely from around the edges to have a better dissection plane. I do this most of the time if the lesion are this lesion is let's say the perimeter is not so big. So you see how good is my lifting right now, and I have
yeah,
a very
this
good
is very
dissection
good.
plane.
I think you can carry on just doing.
Yes, but Pradeep, I most of the times, because okay, this was for me just say an easy one case. Most of the time I'm using data floss clip, especially for esophageal ESD. It's I think it's a game changer for the time of the ESD. I totally agree with you.
Let's see some dissection. We want to watch your dissection skill now.
Of course, right now, if we have the luxury, and of course, here in Greece, we're not a rich country, but if we are switching to another knife like IT Nano, it will be finished in less than 1 minute. But I will continue with dual knife, okay?
Sure.
Okay. So what is good with this knife is that we can inject through the sheath of the knife. Also, you see my assistant is
Very
doing
good demonstration. Very nice.
So we see that it's very minimal to exchange all the time devices. I think this is the main theory behind all the modern knives like Plex knife or from Herbe, all the older ones, jet knives. So we have right now the luxury with the Japanese knives to do this kind of things. Of course, we see a small vessel
Stefanos,
here.
can you ask your cameraman to focus the camera on your hands? We want to see how you're producing such delicate movements. He can't show your hands. Can you? Yes. Okay, now if you dissect, show us how you move the scope. It's very important for audience to watch the control you have on the scope when you're dissecting. Yes,
Okay.
show us now, please.
Okay. So let's go from this side. We see the left lateral side of the lesion. So we try to keep, in order to rotate my scope and have a good dissection plane.
Yes.
Okay, just a small labis. Okay, good. You see a lifting, and then I'm trying to be in a parallel wave to the mask layer.
Stefanos,
Yeah.
sorry, but we have to move on the room number 3.
Okay. Should I finish the case?
Yes, you can.
I've been told that we have to move to the next case. So
Okay.
hopefully you will finish it before we come back to you. But this is excellent demonstration. That's what
Okay.
our audience wanted to see, the control, beautiful tip control. Thank you very much.
Thank you, Bajib. Thank you.
Please, can we connect with the number 3 room?
We are now into the tumor with the needle. We can see clearly the tip of the
The
needle.
part of the Mediterranean Sea. Ciao, I'll see you there.
Thank you.
Judy.
Thank you, Roberta, for the very tough case.
Can we connect with Athens, please?
Can we go back to Greece? Stephanos?
Yes, yeah. Do you hear me? Okay.
Yes, now we can hear you.
First of all, congratulations to Roberta. I think she was much faster than me in a very tough part of the colon. So something else I can show you with the new technology of colon enhancement is that we can evaluate the bed of the resection later with the TXI or LCI. We can see where are the submucosal network, vascular network, in order to do a meticulous coagulation of the vessel. So you see how nice is gonna see all these kind of vessels and see where are penetrating vessels in order to coagulate the base of them. Right here, there is something like this. So we close this. Every time we cast the vessel, we have to retract a little bit our monopolar coag grasper. Okay, and some sorts of burning effect that is, and the vessel is coagulating.
Stefanos,
Yes?
we saw that you before were performing coag grasper hemostasis and you are carry on. But would you explain to the audience in which way you treat the site of the resection in an after an upper ESD, if you treat it?
Sorry, I didn't catch this. You mean to?
How you do your plan of the hemostasis?
Yes. And after the hemostasis, how do you treat the site of the resection? If you use gel, if you use...
Additional hemostatic preventive measures, you mean?
Yes.
Besides coagulating vessels. Actually, I have tried everything. I don't think they work so good for delayed bleeding. So in this area, I try to coagulate every visible lesion. So I prescribe the patient for a 2-month PPI trial twice a day. I think that they are sufficient for upper part of the stomach for a delayed hemorrhage. Sometimes in the duodenum cases where it's so rich the submucosal vascular network there, and you cannot apply coagulation all the time because you are burning all the time the mask layer. Then yes, there we have to clip all the as much as you can all the resected area, and there you may apply sometimes Onyx powder or Purastat or everything chemospray effect you have. But I don't think that in these kind of cases it's gonna to add something better for the patient. Also, the upper part and of course the esophageal side of ESD, the risk of delayed bleeding is not so high comparing to the corpus. If you have a resection in the corpus or at the duodenum. That's my perspective.
Okay, Stefanos, thank you for your beautiful demonstration.
Can I show you my team?
Thank you for the participation to EndoMed. Okay.
Okay.
See you another next year for a new EndoMed.
Sorry, just one second. In 1 second, I have to present my team. Come, guys, come. My team is full of young doctors, endoscopists. They all trained in advanced endoscopic procedures. Most of them they have been trained in Japan. I try to mentor. I'm the mentor of them, and this is the next generation of doctors. So my meaning is to spread our knowledge to the new generations. Thank you very much. Best of success.
Thank you to you. Very compliment. Bye.
Bye.